Today, I wanted to discuss about the human side of being an oncologist. And this was actually provoked by one of my interactions with a trainee in the clinic. The trainee asked me, it was a clinic where we had a number of patients with so-called bad news, where they were not doing very well. The cancer was progressing. And we had to discuss about end of life care and things like that. And so the trainee asked me, and like, Dr. Gyawali, how do you do it? And like, do you enjoy this? Do you hate this? Do you feel sad after it? Do you take it home? Does it reflect on your family life? And that was a very important question. And I think this is a question that needs to be discussed more often in oncology. But for some reason, we try to avoid having these discussions among colleagues, among trainees. We need to discuss these things more often. So how do people do it? The trainees need to know. So what do I do? And I think because this is such an important topic, I wanted to share my answer that I gave to the trainee to everyone through this video. So do I feel sad about it? Of course I do. We have to feel sad about it. It has to hurt us. The day we stop feeling sad about it is probably the day we should give up oncology practice. It should pain us to see other fellow human beings in pain. And that's the reason why I took up oncology in the first place. I definitely feel sad, but how do I cope with it? How do I manage it? I think of it this way. I think these bad news are important junctures in the life of any patient to come to the room and tell them that, okay, you have cancer, you have an incurable disease, the cancer is growing, the treatment does not seem to be working. Maybe we need to stop cancer directed treatment and start to focus only on symptomatic care. Maybe we need to start discussing about end of life care. How does the disease grow? How is it eventually going to take life? How many months do I have left? All these discussions, these are hard discussions. And whenever we are going to have these discussions, it should make our heart feel heavy before entering the room. And we should feel sad after coming out of the room. That is natural. That is just us being human. If we stop having that, then probably we have become too robotic and just become a machine in the process, which is not ideal. The patients do not expect a robotic algorithm to be taking care of them. The patients expect human beings to be taking care of them. And as human beings, it's absolutely okay to feel sad, to feel bad, to feel heavy, to have heavy emotion during these discussions, before these discussions, and after the discussions. What it should not be having is it should not impact our quality of care. It should not impact the quality of care for the patients that we see after this patient. We need to make sure that we're still functioning at an optimum and we are providing good quality care. But of course, we do feel sad. I do feel sad, and it makes me sad. But the way I think about it and the way how I cope with it is because these are important junctures in the patient's life. I have seen some colleagues, some physicians not do a very good job about breaking bad news. And the patient and the patient's family end up feeling even sadder, even worse than what they were feeling based on the objective status of the disease. Some of us do not probably do a good job of explaining things better, or caring for them better in terms of supporting them mentally and emotionally. So I think of this as an opportunity in that if it is not me, there will be someone else who is going to share the bad news with the patient. And what if that someone else does not do a good job? Then it would be even worse for the patient. So I think of it as, okay, this is my opportunity to do it well, so that at least I'm not adding any heart, I'm not adding any sadness to the patient than what the patient already is experiencing. Because breaking bad news is an art, and if you do it well, the patient and the patient's family, they will remember you for a long, long time. Because objectively, the cancer is growing, or maybe the patient has a very poor prognosis. You can't do anything about it. But how you deal with it, how you break that bad news, and how you convey that news, and how you support the patient, that makes a big difference. And it's not uncommon for us to experience situations where we are telling the patient that you have a very short span to live, or you are dying soon, and the patient or the patient's family, they end up thanking us, saying thank you for explaining everything honestly and so kindly. Thank you for your kindness. They end up thanking us for breaking this bad news. So I think as a trainee, we should always focus on how we can do it well without being a robot, without being a machine, how we can show our empathy and take care of them at the same time. And we should always think of this as an opportunity to do it well, so that we make a difference in their lives, in their memories, because there is always a chance that someone else might do it worse. And that's how I think about it. And that's why I don't shy away from all these bad news discussions. I never say no to having all these bad news discussions. I think of it as an opportunity to do it very well and to make a meaningful difference in the memories of the patients and the families. And do I take it home? That's a very difficult question to answer. Sometimes you do. Sometimes your patient dies, and in oncology, you keep seeing the same patient for a long, long time. Thankfully, because some of the cancers have good prognosis, and you are seeing these patients every 2 weeks, every 3 weeks for 18 months, 2 years. And sometimes you end up having almost like a friend-like relationship with the patients, and the patient dies. It is very difficult to take. It is heavy. But I try to make it a point that when I reach home, sometimes I share it with my spouse, with my partner, because it makes my heart feel a little bit lighter. But and it will also depend on what your family situation is, who you are living with. I have 2 kids at home, and when I reach home, I try to focus completely on what is at home, and I try to give my 100% to my family. But having said that, sometimes you do carry it home, and again, it's okay. I don't think we should think too much about, oh my God, I'm at home and I'm still thinking about it. It's okay. Sometimes you do think about it. We should not read too much into uh, making a hard line about, okay, I'm home, so I'm 100% at home, or I'm at work, or I should not be feeling this. No, we are human beings. I think we should just naturalize our emotions, and it is very helpful to have like good friends and colleagues at work with whom you can share these feelings, because they will also be going through the same things. A colleague with whom you can just chat whenever you're having these emotions, a colleague with whom you can go and have some drinks. And these are all coping mechanisms. And yeah, I think the bottom line is, it's okay to feel these emotions. Just because you're an oncologist and just because you do it for 10 years, 15 years, 20 years, does not mean that these emotions should just disappear. If these emotions disappear, then probably you should not be an oncologist anymore. That is what I think. We should be feeling empathy for our patients. We should be feeling sad for them. And that's why it gives us motivation to do even a better job to help them. And I guess everybody may not agree with what I think, but this is what my philosophy is, and this is how I have been dealing with this. And at the end of the day, I think we should talk about this more often. You don't hear people talking about it. People pretend as if everything is okay, and people pretend as if it does not touch them, but it touches everyone. So we should normalize having these conversations.